Hello and welcome to the TRI online
Hello.
webinar with Dr Teles. Hi, good morning everybody. My name is Holger Kast. I'm the Global Training Education Head of for TRI Dental Implants. Today we're going to start a triple series of webinars with Joel. We would like to do it this time a little bit more interactive for these webinars. The next 3 weeks actually. So the topic is going to be immediate placement and immediate loading in total. But before we go into the presentation, I would like to introduce you quickly into the TRI implant system. Actually, TRI means through research innovative, and we are 100% Swiss made company. All products are done made and produced in Switzerland. I think the main goal of the system is the simplicity. So we have a very lean surgical kit for a bone level and a tissue level implant, the same drilling protocols for these two types of implant, and the narrow implant system is in there as well. I think Joel is going to show this simplicity in his presentation a little bit closer in a few minutes. And one main focus right now is the Think Digital. So we are having already in our existing portfolio a lot of digital components where you can do a full digital workflow in your daily business. And I think at the end of the presentation, I'm going to introduce you in our digital festival, which we plan on the 25th and 26th of September this year. Also with Dr Teles, but for these details a little bit later after the presentation of Joel. As I already said, we have a triple series of presentations or of webinars. And the first one is focused on the single tooth restoration with immediate placements and immediate loadings, from molar to very aesthetic zones. I think it's going to get very clear that tissue management is a very big key of aesthetic implant placements. And on the 8th of April, we're going to present more about full arch restorations. Joel is, I think, is going to explain that much more detailed. And on the 15th, this is something very unique, I think. We want you, everybody who is listening to this webinar, also in this presentation right now, we want you to be interactive. Therefore, you have on the right side a toolbar, and there's a question mark field. And in this question mark field, you can ask all your questions. I'm going to moderate this presentation of Joel, and don't blame me, I don't want to annoy you, but we both got clear that we want to do this webinar a little bit more interactive. So I passed the questions of you guys, of the audience, to Joel during the presentation, but I already see we are more than 200-300 now already signing up for this or are in this webinar right now. So I can't pass all the questions, and therefore we have on the 15th of April we have a summary webinar where we can talk about all the topics we were talking, or we can discuss about it. And please write us during the next weeks your questions, and it's also meant to be that you can send, for example, X-rays, CBCT scans, or maybe some cases of yours, which I and Joel will implement in the presentation of the 15th of April at 11 o'clock. And so we try to discuss all about our main topic, immediate placement and immediate loading. So enough for my words. I would love to pass the words to Joel. Joel is sitting in Portugal. I'm sitting in Switzerland. Hello, Joel. And
hello, my friend.
How are you? Yourself. I've switched to your computer right now.
Okay, thank you.
1 second. I have to change this here. Okay, now you should have the rights.
Okay, now I should be showing you my screen. Do you see my screen, Olga?
Yes, everything perfect. I think you
Okay.
can start.
Okay, so let's start. Okay, first of all, thank you all for being that side. Like you all, I'm also staying at home. In this thing that we are going through, it's important, and so let's try to keep our mind occupied a little bit. And that is why me and Olga have prepared this series of 3 webinars for you. So I hope you all are all good and your family as well. And let's do this as interactive as possible. So this is the 2 universities that I went through. So first of all, I started in this university here, CESPO, and then after 2 years, I moved to this FMUDUP, Faculdade de Medicina Dentária da Universidade do Porto. I finished my education in 2005, and as soon as I finished, I set on my own practice. It's in a beautiful city called Peso da Régua, and this practice of mine is right in the middle of the wine region in Portugal, the oldest demarcated wine region in the world, where Oporto wine comes and is going through all over the world. I'm sure you all heard about Oporto wine, it's made there. So I'm lucky enough to live in such a place. And this is the view you get out of my reception in my clinic. So I try to be I try to have multiple activities during my life, and this is one of them. I'm also a guitar player. I play in a band called Capitão Mocho, and we have an album from 2016, I guess. And that's a part of my life that I really enjoy. And now I'm also doing this other thing, like we're doing now, because in 2017 I met this guy, our host today, Olga. Because, hello, Olga. Because I was invited to do a class about full art approaches on iron education in Oporto, and I get to meet Olga there. I get to meet him, and after he came to me and he asked me if I was able to do this more often. At the beginning, I was not very sure about it because I was not documenting everything very well. I was not prepared for it. So I asked me, okay, give me another year. Next year, I'll give this class again. I'll be more prepared and we'll talk about it. So the following year, in 2018, we met again. I did the class again, and afterwards, he made me the same invitation, and therefore, till the present, we were traveling around the world together, and our friendship grew and grew and grew. and we go to small practices. This is not a small one. Actually, this is one of the biggest clinics in Europe, giving training to their senior doctors. We receive people from all around the world to our courses. We also do practical ones with hands-on and discussing surgical techniques and restorative techniques. We do lectures as well, and till this moment, I never cease to amaze me the amount of people that can listen to us, and I feel really thankful to you and to TRI for trusting me and my work. And so let's start. Let's start with this immediate implant that we are discussing today. And the first thing we need to understand is why. Why should we perform an immediate implant? So for that, I'll bring you 2 articles. The first one is from Last Drop in 2003, and it shows you what happens once you extract a tooth. So you realize that it's a prospective clinical trial, and when you extract a tooth in the 12 following months, major changes occur in the site of the extraction that we all know. And it proved that the width of your alveolar ridge was going to reduce by 50% during that time, and that 2/3 of these major changes occurred in the first 3 months. So it's an early process. This article is also very good from Araújo and Lind, and it clearly shows you that at the beginning, in the first week, your buccal bone is even higher than your lingual buccal bone. But As time goes by, in just a month, it starts to decrease. And after 2 months, this is really, really a big depression, and it will keep on, as you now know. And also the width will reduce. So with this in mind, every time you need to extract a tooth, that's a question you should ask yourself and discuss with your patient if you can do an immediate loading, an immediate placement there in order to preserve this architecture of bone and tissue. So that leads us to the other question. So when can we immediate place an implant? So for that, I like this simplified classification of the socket. And normally type 1, you have everything in place, being bone and tissue. So normally it's not that difficult to do the immediate placement and even the immediate loading. In number 2, in type 2 sockets, you don't have, you lose a wall of bone, but the tissue is still in place. So if you understand the right techniques, you can still perform an immediate placement and immediate loading. And on type 3, it's not perfectly clear now, and you're going to see why further in the presentation, but in theory, you should reconstruct the ridge first and then place the implant after 6 to 9 months, and then try to do your restorations. This is another article that I found useful for this. It's about the sagittal root positioning for maxillary teeth from canine to canine, from Khan in 2011. And thankfully for us, most of the maxillary teeth are in class 1. So the root is turning to the buccal side. And this allows us to have better anchorage in the right positioning for the final restoration. So it's the better outcome for us. And luckily, it's more than 81% of the times it happens like this. Just a reminder that the author says that in class 4, you should not perform an immediate loading because the root is touching both buccal and palatal walls. So let's start talking about clinical cases. So normally in the molar side, I do not perform an immediate loading, only an immediate placement. So the first thing we do is, of course, extract the tooth that needs to be extracted, and we perform an atraumatic extraction. Now, for this, only one small tip. Normally, first of all, we cut the crown, and then we start with the drill, separating the roots. Now, the small tip is that I never go completely to the end. And this is because once you get to the point that you lose the counterforce of the remaining tooth, you go and you may harm your tissue. So I'll leave it a little bit, and then I will break and separate the roots by fracture instead of with the drill. That allows us to get to the final of the extraction with your tissue as unharmed as possible. Then the next consideration you need to have is what's the right positioning for your implant. So in molar side, yes.
That's already the first question. Yes. How long does it take you to get the roots out in this technique?
Well, there's no answer for that because it depends on the anatomy of the root. I may have an idea at the beginning because of the CT scan that I always do. So I have an idea the right approach for each case, but it depends a lot. Okay, so there's no easy answer for that. But I will take as long as necessary because the rest of the surgery depends on that very moment you extract the root, and now you keep everything after the extraction. So I'll take my time. Okay, so normally I prefer to use octa implants in these situations if the bone that's left in between the roots gives me comfort enough to place the implant and have the feeling that it's going to the right place and I have enough big bone implant contact. If, and this is the x-ray after this particular case. But if after extraction I find the ridge to be too thin and I'm worried that if I'm going to drill through it, the ridge, no, the bone in between the roots, it's too thin, and if I'm going to drill through it, I may end up with nothing, therefore getting less primal stability and less bone implant contact. So in these situations, I'll normally choose one path of one root, and normally the palatal, and in lower jaw, mostly the distal one, and I will lean my implant just touching against the existing bone. Okay, so therefore I'm promoting more implant being in touch with the bone. I'm getting better primal stability, and in these situations, for me, that's why I don't do DTR all that often, drilling to roots. I like to see what I have, even though I have a clear image of what I'm going to get with a CT scan. I like to see it. And you waste drills doing DTR. In theory, you should use one for each case. So then I'll perform the customized healing abutment. Normally, like I told you, I don't do immediate loadings in molar sites. So what I do is this: I do an individualized healing abutment using PIC abutment or titanium ones. In this region, I use one or the other with no difference. And then once you done this, test it, you know that all your profile is covered, you do the filling, and you place your individualized healing abutment. Now in these types of procedures, I don't use sutures no more, so it goes exactly like you see here.
Quick questions in between.
Yes.
What type of placement do you prefer? Consider subcrystal or regularized to the bone level?
It depends on the type of implant. If I'm using a vent implant, I will place it more or less 3 millimeters.
For the tissue level.
For the tissue level, I will level it up with the tissue. Normally, right. I'll go a little bit inside, yeah, to be safe, yeah, but not much. And you get to see here in the end result exactly what I'm telling you. So after 3 months, if you do this correctly, this is what normally you get. You can see here, even in this X-ray, you got the before and the after the surgery X-ray. We've done these three teeth, and you can see here that in this tooth right here, we had like 4 millimeters high. Here it was less; it was more or less 3, and here in between 4 and 5. So even in these very tricky situations, if I was to extract this teeth, what I would end up is having to do a caudal look afterwards, okay? Because the sinus would prematize, and you end up with a bigger surgery, bigger treatment time, bigger morbidity, everything that comes with it, and higher cost for the patient. So if we plan carefully and we think we have the possibility to place immediate implants in these case scenarios, I will, 100% of the times. And so this is a closer look of what you get after 3 months. And with Octa implant, like I showed you, yes?
There was one question to the slide before. You can see in the X-ray a very thin bone, like about 3 millimeters. Can you show these X-rays again? How can you be so sure of placing the implant in a very thin? Maybe you can show it with your cursor. Very thin bone height.
The height is very limited because in the CBCT scan I could see that the roots were very separated. Okay, even though they don't look like it here, they were. So the bone in between them was very good for placing the implant, and so I knew I could place the implant there and still have good primal stability and still have very much a good percentage of BIC. Okay? So that's why. And of course, in the same scenario, if the roots were very close to each other, and the height is not enough, I don't have enough apical bone, I couldn't, like everybody else, so I would do a socket preservation and go in a second time. So it all depends on the CT analysis, okay? If the CT scan shows me some opportunity that I can use, I will use them and I will perform immediate loading. Because even if you do a socket preservation, you will not get to this result with just, after the second surgery, you know, you do the ridge preservation, you go in, the socket preservation, you go in a second time, and already you lost the papilla, already your tissue is flat, even though the volume might be preserved, the anatomy is not the same. Okay? It lacks information to keep in the same place. And that information is given by the customized healing abutment. And that is why you can get to this result with just one surgery, okay? If you're doing two, it's not the same. You have to reset the biology to create the emergency profile. So if it is an Octa or a vent implant, you can expect the same results, okay? And
Maybe
therefore,
here
we just
I would like to add just quickly. You
yes.
just saw the bone level implant of TRI and the tissue level implant with the same thread design. This is what I meant in the beginning. It's very simple. You have the same drilling protocol and the same surgical kits, the same drills for tissue and bone level, which makes it very simple. And before I pass to you again, there's one question from Tina Sar. How long do you let it heal with the individualized abutment before placing the final crown?
It depends on many things. It depends on the amount of implant that is actually touching bone instead of graft material. So if it's touching mostly bone, 3 months. If it's touching more biomaterial than bone, 4 months, 5 months, it depends. Okay, but more than 4.5, almost never. Okay, in between 3 and 4.5, more or less. So you got tissue stability with just one surgery. This is the crowns after placement, and of course with tissue stability you get bone stability, so over time they were likely to stay exactly like you left them. So now once we enter the premolar sides, I normally go with immediate placement and immediate loading. Okay, so from here forward, I always try to do an immediate loading. So this is just a reminder of the last consensus is about what the definition terms of immediate loading. And here you can see that they say that it's if it's earlier than a week, it's still considered to be an immediate loading. But all the cases you're about to see today and the next webinar, the restorations were done, the provisionals, in the same day of the surgery. And this for me is very important. I really do not like, and I've been there, of course, but I really do not like to place provisional restorations in 72 hours or in 48 hours. I really don't. So it's everything on the same day of the surgery. And of course, you need to have these notions about ISQ, and you have to understand that there's a non-linear correlation with micromotion, so it decreases more than 50% the micromotions in between 60 and 70 of ISQ. So higher than 70, you're safe to do your immediate loading in single tooth approaches. But you can also see the correlation in between torque and ISQ. So right in between 32 and 35 newton meters of torque, newton centimeters of torque, you can also perform your immediate loading. And of course, you have to consider everything else, the health of your patient, the oral condition, the periodontal status, everything that you already know. So all this comes into mind when you're planning the case and looking at the CBCT. So okay, let's start with this case. This case is about a fractured premolar. It was an endodontic treatment tooth, and you can see here that there was 2 fistula associated with this infection. It was on antibiotics on the surgery day for 4 or 5 days. I don't recall. I went yesterday trying to find out if it was 4 or 5, but I guess it was 5. And to turn this acute infection into a chronic one. So you don't want to go in once the infection is too acute because it's too risky. So he was on antibiotics and on chlorhexidine for a few days now, and this was actually case of the month in 2018. So this is a 2016 case, one of the first I did with TRI. So I performed a traumatic extraction. In this case scenario, I didn't even have to separate the roots because it was very easy to they were already very loose. And afterwards, I do the removal of all the contaminated tissue. Now, as we speak, I don't use anymore. I used to use metronidazole to irrigate my socket, then chlorhexidine. I used a lot of stuff during the years. Nowadays, I'm only using disc corrects and saline water irrigation, and that's it. And I clean, and if I think I clean enough, I clean a little bit more. It's exactly like this. And for this, I really like these Luca Correttes. They are sold by a company named Schwertz, and the sense of grip that they give you, it's really nice. So this is something that I always use, and once we tried it, we can never go back to using the old Correttes. I cannot live without these anymore, so that's why they're here. Now, in premolar sites, I always aim for the middle of the socket again, placing my implant. I know that some colleagues of mine prefer to use a more palatal approach in order to get more big, but depending on the eye of bone I still have after my root, I prefer to place it right in the middle. This is an area where the bite forces are tremendous, and so if I have the neck of my implant right in the middle of the socket, I believe that over time it will handle more safely those forces, and our results will be more stable over time. That's something to have in mind as well when you're placing implants. So after I place the implant, I do my provisional restoration. In this case scenario, I use the extracted tooth. We'll discuss how to make provisionals further on the presentation because they're much more important in the aesthetic zone. So don't worry, we'll get to that. And after I try my provisional restorations, I know everything is in place, I fill the gap, and then I place my final restoration. Again, no sutures needed. And this is the X-ray on the hand of the surgery. From premolar forward, I always use PEEK abutments. I really do not like to use titanium in the situation. And more importantly, from canine to canine. The only disadvantage I see with PEEK abutments is the lack of radiopacity, so you don't get to see them in X-rays, but all the rest is better. So the biocompatibility for me is better. You don't have to use OPEC, so you take less space, and the bonding of the existing tooth or the whatever material you use under the provisional restoration is easier to this PEEK abutment than it is to titanium. So I much prefer this. And in 7 days, this is the post-op. Yes, Olga.
Sure, and hi. There's a lot of questions, really good questions actually. There's one from Noor Kamil. Do you also decide to immediate loading based on the keratinized tissue you have before you do the extraction? So is a tissue a discussion point for you?
Yes, always. If you have to enhance even we'll get to that, but if you have to enhance the biotype, if you have to add keratinized tissue, of course. But normally in situations such as this, if you're planning on doing this, the destruction of the architecture is not that big. If it is, maybe you should not do immediate placement and immediate loading in these type scenarios. Of course, I'm not discussing full arch or multiple teeth scenario, okay? Because that may lead us to a different discussion, okay? But in this scenario,
sorry.
Yes. No.
There's a question from Francisco Roca. Don't you try to have a gap more than 2 millimeters to the buccal bone?
Yes, I do.
I think you answer this later on. Huh?
I will answer that later. Later. Yes. He's perfectly correct. Yes. So after 3 months, this is what you can expect to happen, and you can see that the tissue is in a really good aspect. The papillas are in place, the volume is very good, and if you take a closer look after a closer view, you get to see that we have our implant and we have very thick tissue around our implant, which is reassuring for us once we decide to go to the final restoration. And as you know, if tissue is stable, bone normally gets stable. So it's time to go to our final restoration. And with this, I would like to make some considerations, because you work yourself to have this beautiful emergency profile. Now you cannot ruin it with a bad restoration. You need to think that most of the peri-implantitis we get is from the restoration itself. So we need to think the type of restorations we want to do. So for here on, the workflow is fully digital. The scan, the bench scan will scan the model and turn it into a virtual one, and I'll get to discuss with the lab everything via digital in the digital workflow. So they use the scan bodies, they make a model, a virtual model, and the aim of that is that we get to choose the tie base, the correct tie base for each case, and we can discuss the type of framework that we're about to do, and the final. Yes.
Sorry, because I think we go now in final restoration, and we go a little bit more in the prosthetic part. Before I let you go in this, there's a lot of questions regarding bone graft materials, what type of graft materials, is it, so to make it clear again, because you didn't use any membranes, maybe you can just say like what types of bone graft material you use, and that tissue, the temporary is more or less
yes, but that's a very big discussion that we should have in Q&A, because in the third webinar, because there's a lot of things that you are going to see that are a bit controversial. Some have literature behind them, some don't, but I will explain you my point of view, that in some parts may be controversial, but I don't like everything black and white. I like mixed colors. So but regarding the materials you saw xenograft, you saw alloplastic material, and even real bone from the patient. So you've seen it all in these cases. I tried them all, and I have different opinions in different scenarios, but that's a long discussion. And yes, I didn't use membranes there. Yeah, but that's another big discussion to have, that we should have it on Q&A.
Before we go back into the digital world, I have one last question. I think we had it before a little bit, but maybe you can answer a little bit better, because in our case, the TRI implant has a 0.5 millimeter machined part. And I think you answered already, but I saw this question many times. And in this moment, I have to tell you, there's a lot of questions. We're going to answer many of them. We filtered them on the 15th again, so I can't pass all the questions to Joel, otherwise we talk here for the next 3 hours. But maybe you can just tell how you place the implant, is there a matter of the polished parts subcrystal or not, and maybe you can just say some words before go back to the digital prosthetic workflow.
The normal answer for this is that you should go 3 millimeters below the tissue line. Okay, that's the normal question to that question, the normal answer to that question. So afterwards, you get this frame of zirconia, where that it's going to be cemented on your tie base that you selected virtually, and then your lab does the cementation for you. That's way better, because it gets to clean very well the cementation line. You don't want cement inside of your tissues, and that's what we tend to call a screw cemented restoration. Okay, and what's missing is the ceramic that the lab is going to apply later. So it's fused, not cemented. And this is a true zirconia ceramic restoration. So what does this mean, the true zirconia ceramic restoration? It means that the ceramic only comes from the tissue up. It does not go inside the tissue. What's going inside the tissue is only the real, very well polished zirconia. Okay, and the cementation lines need to be thin, as you see here, and very well polished. There's no cement hanging, because you know that for the tissue that will be a trouble. So once you get the restoration in, this is what happens. So I learned these principles with this guy here, from Thomas Linkvicius. He now has his book going on, the Zero Bone Loss Concept, and I highly recommend it, because it literally opened my mind for some parts of mostly restorative procedures, and is very, very, very versatile in these types in restorational world. He himself is a prosthodontics, so it's much more a restorative course than a surgical one, and I learned a lot from this guy. So I went to his first ever course, and one thing that he clearly can show you is this difference in between a plaque zone and an adherence zone. So the adherence zone is where the zirconium frame is, and you get some attachment of that tissue to that zirconium frame if it is really well polished. And the plaque zone is where the ceramic ends. So in that position, you never have adherence. And these concepts that he had, and that we can clinically see, really made an impact on me. So I was in his first ever course, and at the point we were discussing the tie bases, because we all had the same problem, decementations and therefore fractures, once we were dealing with monolithics or zirconium frames over tie bases. And this, at the moment, I couldn't understand why this was happening to me, and I could see that this was happening to a lot of people as well. And he explained this to me perfectly, because he had done a bunch of tests, and two things were happening to everybody. First of all the tie bases were poorly designed back in the days, and they were always the same height, and they didn't have any mechanical retentions on them, and therefore the labs were sandblasting them in order to then put the cement, thinking that this would add grip and the cement would work better. But it can show you perfectly that in fact this gets to a worse result. Therefore you get more decementations and more failures, because after the cementation normally it will break, or sometimes it will break. So what TRI has done for us is now that your lab can choose from multiple heights and even individualize your tie bases, which they call tri bases, and you can even screw them into up to 20 to 25 degrees angulation. So this helps us to the amount of problems we were having back in the days is now way less, because as you see in the digital world, you get to choose the height of ideal tie bases for that case and the shape, and you can use their tie bases, which by the way have a rough surface by them, and the cement will hold firmly, and you have really better results using monolithics or zirconium frame cemented, screw retained cemented restoration. So back to our case, this is what you have as a final restoration with what I think is a perfect integration. A pillar are in place, volume is in place, and this is what you have. Now, for the ones that did the question, what about why didn't I use membranes? This is a question that I was asked a lot back in the days when I started publishing these cases. Like I told you, this is a 4-year-old case. This is the final restoration, and you get to see something. This is the X-ray of the post-extraction case, and this is 2.5 years post-op, and you can see how thick the buccal bone is at the moment. That leads to stable. We have stable tissue, therefore we have stable bone, and we have this type of condition on this implant in what I found to be a tricky case due to that big infection you just saw. So let's move into more interesting stuff. Let's talk static zone. Yes.
I would like to pass one question, and this is, sorry, I can't see who it was writing. How do we decide the height of T-base according to the zero bone loss concept? First of all, I would like to say that also TRI in this tie bases you just saw, you can individualize them as Joel perfectly described. We have also two different gingiva heights. So actually the tie base, when you do this tie base procedure, the cementation is out of the mouth, so you have a very clean surface environment surrounding the bone, or not, you are away from with the cement gap actually from the bone, but anyways there is no cement really showing on the surface, so no influence to the bone with a tie base technology. But anyways, we have it in a 2 millimeter higher one. If you have a very thick tissue, you can use the gingiva height of 2 millimeters. So to be very safe of no zero bone loss concept.
Yeah, and for that, what Link Vicious used to say is that you should use the higher you can. So if you can use the 2 millimeter one, you use the 2 millimeter one. It depends on many factors, and also in the width of your implant and the type of tissue you have. It depends on many things. But if you can use the 2 millimeter one, you should. So in static zone, the first question you need to ask yourself is how do you choose the right implant diameter? So for a long time, I was using the same technique that everybody, and I was measuring from mesial to distal, and therefore choosing my correct implant diameter. Nowadays, I'm following this protocol from José Carlos Rosa, that is the author of the IDR technique. It's a very beautiful technique that you should look if you don't know it yet. And it tells us that you should do that measurement from the palatal wall to the buccal wall, and therefore choose an implant diameter that allows you to have this 3 millimeter rule, that you should have 3 millimeters for accommodating tissue and for grafting in between the implant and the buccal wall. This is for better and more stable tissue results, and therefore more stable bone. And for this, we have all these types of implants with TRI, from the 3.3 to the 4.7. 4.7 we mostly never use, but in between 3.3 and 3.7 are the most common, and sometimes the 4.1. So to be perfectly clear, in aesthetic zone, this is the case that we are going to see from the start to the end, okay? But in between, I will go into tease you with other cases, okay? But keep in mind this picture, this is the case that you're going to see in the end, the final result, adding up all this information that I'm about to give you using different cases. So this was a central incisor with partial loss of the buccal bone again. So you can see here that this is class 3 on the classification that I first showed you, because you have bone loss and tissue loss, but the tissue loss is not very, the distance is not very long. It's about 2 millimeters, 1 and something millimeter. So in my mind, up to 2 millimeters, I still can do something immediate. If you go higher than this, then the risks become too much and you may end up with not that good results. But if the distance is not very, very big, I try to do everything in one surgery one time, mainly because I'm lazy, okay? But the first thing I do is that I map my defect, okay? So I'll go with the probe, I probe it in this higher part, and I'll go mapping it around to see how the defect is. And you can see here, marked in blood, exactly the shape of the defect we are facing. So this is the highlight of that defect, and this was the scenario that we had in this central incisor. I'm sure you all agree this is a tricky situation, no buccal bone. The tissue does not look all that good. It has, you already lost like 2 millimeters, so you need to be careful and plan very careful approach to a case like this. So you perform an traumatic extraction like always, and you can see here, like the first tip, these lines draw there. We'll discuss them in a little bit. So an traumatic extraction is no different than the other sites that you have. First of all, I always use a 15C blade or a microsurgical blade to do the intersulcular incision. And then I use this instrument all the time, the Pilox periotome, that you go in the palatal, in between the root and the palatal wall, and you start making circular movements here, separating very well the bone from the root, okay? And I'm very gentle using this. I've tried some other ways of extraction. You have Banex and other stuff. I prefer to do it like this. This is my way of approaching these roots. And after you extract the roots, you clean everything, you decontaminate, you remove all the contaminated tissue, like I told you, and then you have to understand the drilling procedure for aesthetic zone, from canine to canine. Actually, I use this more often than only in aesthetic zone, but for other purposes that are not up to discussion now. But you need to understand this double trajectory technique. So first, you do your approach like 3 millimeters below in the palatal wall, and at 45 degrees, you do your first puncture, and you puncture more or less 2 millimeters. After those 2 millimeters, you start to change your trajectory, aiming that your preparation for your implant is leaning on the palatal wall. So if you use the ideal position for a restoration in aesthetic zone, you realize that your implant should always be placed touching that that palatal wall, and this is why this double trajectory is very important. You can get to see here a CVCT of exactly what I'm telling you. So this is 1, 2, 3, 4 steps of what I just tell you. And the funny thing about this is that you can actually see in this picture here the bottom of the socket, and you can get to see our new socket being prepared for our implant. So it's different positioning, like we were just discussing. We don't follow the route. You remember that 2011 classification of Kahn. And you can see here the space for the grafting material. So after this, we go for our provisional restoration. And now I'm going to try to give you some thoughts about provisional restorations. Like I told you, I always use PIC abutments, and they allow me to draw on them and reshape them. So I'm comfortable enough to remove them, reshape them, and go in again. Once I'm sure I have space enough for the restoration, I'm ready for beginning my provisional restoration.
You did not show this picture before. There was already a question from Francisco Roja. Don't you be more concerned using peak abutments without radio parking according to zero bone loss concept of no causing bone compression? And,
I didn't understand.
I think it's like about like the peak that you don't compress the bone too much. The design of it, maybe.
No, you will see. You will see. You will see.
I think so. I think
further in the slides, you will see. Yeah, I guess I understand what he said, and the answer is, if he was talking about that profile that you saw on the peak abutment, you have those very wide ones and you have thinner ones. So choose the right peak abutment. That's the answer. So in order not to pressure the tissue, that's the answer.
No graphic control, is he writing? Okay.
Oh, right. Yeah, that's the only disadvantage. That's a real disadvantage. But for me, weighing everything, that's the only disadvantage I see. The rest is all advantage. So I go with peak. Okay. Just a small tip here. What you see here is a jig that I made myself out of composite, that if you relax experience, it helps you. Once you extract the tooth, you can always go back to the same positioning. Yes.
Just one more question to your slides about the buccal wall and the drills, how you start the whole thing. What drill do you use, lens or pilot, for the double thread strategy, you know?
Both. First the lens, then the pilot.
Okay. Thank you.
And afterwards you can go straight. That's the answer. So this jig is very important if you are less experienced, and if the tooth is in the right positioning. Sometimes it may not be, but if it is, you can do this before you start your surgery, and you prepare this, and afterwards you can put the veneer you're about to create in the same positioning, and always go back to the same positioning of the tooth. This is an easy way to do it. It's very practical, and it takes you almost no time and no money. It doesn't have that much costs. So always keep in mind that you should go to the procedure of acid and bonding in your, if you're using a tooth veneer. And this is what you get. You remove everything, you cut everything, and just leave this veneer. I try to leave the mesial and distal contacts because it helps me to put it back in place as well. If you cannot use the tooth that you just extracted, if you don't have the crown anymore, or if you have a ceramic restoration that normally breaks during extraction, you can do a composite veneer. There are two ways of doing it. Or I take an impression and use this and create one myself or the lab, or I directly do a reconstruction over the site, do again this silicone mold on it, and then do the veneer. It's always an easy procedure. You can always find ways to do it, and you end up with the same thing, a veneer for your case.
There's just a thank you for you from Milan Damani. He says, amazing tip for the jig technique, you know.
Good. Very good. Thank you. So you go in with our veneer that you prepared, and you place it in place, and you start sticking it to the peak abutment using composite, and really closing all these gaps here. So you keep adding up material until you get to this point. So afterwards, it's stuck, you got everything, your socket is fully covered, you remove this provisional restoration, and normally this is what you get. So again, you can see the line, we'll discuss it in a little bit. It's full of blood, it's out of shape, but you have a restoration that you can work on. So, and while I'm doing this, and this is very important, my assistant is always keeping the tissues very moist. With saline irrigation, she's always irrigating the tissue, because at this moment the patient is waiting and I'm preparing this, okay? So I'll come with flow composite, and I'll slowly start to reshape all of this. And for that question that somebody asked, you can see here that the peak button is not that wide, is not making any compression. And we'll reshape it and see, we'll start to reshape it, leaving space for the tissue, thinking about what José Carlos Rosa told us about those 3 millimeters. Afterwards, I'll go back into the patient's mouth, and I see what I need to reshape. Okay, this is my first trial. I look at the crown and I see where it's compressing the tissue. What do you feel once it gets in? And you take it out again and you reshape it. And once you're sure everything is in the right position, and you're ready to go. Okay. So what are the main considerations for these provisional restorations? It doesn't matter if it is extracted tooth veneer or composite veneer. It's the exact same protocol. What you need to think is that both the buccal side and mesial and distal walls need to be shaped to be concave, allowing space for the tissue. The thicker the tissue is, the more stable result you have. And if you have space for tissue, it will come down and accommodate. If you don't have space for tissue, it will go up and go thinner. Okay, this is tissue engineering. This is thinking biology. The only part I don't really care is the palatal one. That one can be straight, it doesn't matter, but buccal and mesial distal is very important. So how do you define this? You can either see the remnants of the line there that you keep seeing over and over on the slides. So this is the main consideration you need to understand: the critical contour, the subcritical contour right beneath it, and the subcritical area, which is the area that you need to touch to create this perfect profile to accommodate your tissues, to give them the information where they should lean, where they should be. So this is a small video. I guess you are not going to hear music. It has music, but you're not going to hear it, I guess. Of our crown being placed. This is a try. The graft is not done yet. I've done the reshape of this provisional, and I am just trying it, seeing how it fits, trying to understand if it makes to compression in some place or not, trying to understand if all my thoughts about the emergency profile are correct, and checking, of course, the occlusion. So I tell my patient to bite, and I'll check lateral movements, protrusive movements, and I have to make sure that it's not touching at any point. Okay, so this is how I try my restorations before I go on with the surgery. So back to our initial case, and you can see here the immediate post-op, and of course that in immediate post-op the situation is exactly the same, but you can see that the tissue is more or less unarmed. Okay, so the possibility for good healing is better. We always try not to arm the tissue, and you can see that the biotype here is not that good compared to the rest. But I didn't do any grafts. Look at what starts to happen. In about 2 weeks, you can see the tissue forming and coming down, and you can see that the lines here are now closer to each other. So the gap is narrowing. This is only due to one thing. While I was preparing this crown, this provisional restoration, I was looking at this profile. So I was not placing my implant and making my provisional restoration thinking about where this all was. I was thinking where this was. And this is the thing I told you at the beginning, up to a certain point, and if you are experienced, you can play a little game with biology, trying to make it work at your advantage. This is a typical case of that. We'll get to that in just a second. So after 3 months normally, and again, it does not always have to be 3 months, but mainly 3 to 4 months, this is the type of results that you can expect. So your biotype is around your implant is very good. The amount of tissue you have is also very good. The papillas are in place. Everything is ready for the final restoration. So you don't want to mess this up. You've been waiting for this to come to this beautiful point, and now if you don't do the next steps correctly, you end up messing with all of this. It took you so great care and time to create. So immediately once you remove, this is an image that I like a lot, because always the tissue immediately starts to shrink, you know. So what I normally do is this: I pick up
one quick announcement, because some people are complaining about the short video didn't work. You guys, you know, whole world is now online. Worldwide, there's so many internet usages, and we are very sorry. But we are doing a video recording of this whole presentation, so don't worry. You can, everybody who is participating in this webinar can watch the video afterwards. So continue with the.
I'm sorry,
Yeah.
I thought you were watching the video. I knew the sound was not going out, but I thought the video would, so I'm sorry. Okay, so I pick up my provisional restoration. I use an analog. I screw it in place and use a bit of silicone and place it in, deeply in. So I let it go hard, and once I remove my provisional restoration, this in the middle is what you get. So you get a copy of your emergency profile that you have on your patient mouth. So I place this abutment, impression copying abutment on the implant analog, and I fill the gap with flow composite. Therefore, what I get is this that you see underneath. It's an individualized impression copy. Okay, so this goes into our patient's mouth, and now we know, and you can already see that it's compressing the tissue, even though it's the exact same shape of our provisional. Okay, so if I was not using this technique, I would lose information, and therefore my communication with the lab would be bad, and therefore my final restoration would end up losing this volume that we created. Okay, so it's very important to keep this in mind. It's a small thing, but it's very important.
I know you are just now explaining the impressions, but anyways, for the temporaries, there was a question: do you ever splint the provisionals to the neighbor teeth?
No, never, ever. One thing or the other. If I don't have enough torque, yes, but I will not screw them into the implant. I will do Maryland, adhere to the adjacent tooth, trying to create again the same principles, but only glued to the adjacent tooth, or I'll go and do it like this, screw, not and don't unite them to the adjacent tooth.
Just to the design of the temporaries, you do them always out of occlusion. That's absolutely clear. Are you doing approximately contact stronger or no contact to just like how is that?
You mean the contact points to the adjacent tooth, 5 millimeters to the peak of bone, I think, in papilla. Yeah. So yeah, there is contact. Not all the times, because Steigman have some thoughts about this that are very interesting. But some patients, they have the asthma, you know, and when they lose one teeth, you cannot think about that contact. Otherwise, you'll end up with a very large tooth compared to the contralateral. So, and in these situations, I try to follow the tissue if everything is in place, and it works the same way, even without that contact. I didn't prepare nothing for that, but I have some cases for this. So the next step is to communicate with the lab the anatomy of the tooth that you're trying to copy, to mimic. It's all about mimicking nature. So the next tip is always do macro photography, and most important of all, use this. This is actually the ceramic the lab is using. So I always ask the labs to send me samples of the ceramics they are using, and I photograph those ceramics, okay? So I don't use Vita scale or whatever scale, because they're all different from one another, and you'll end up losing information. So I use this. This is, you know what this is, Olga? This is, you know, that things that you use to for the coffee, the sugar in the coffee. That's just it with a bit of ceramic. And so that leads you to
question from my side, actually. So if the dental technician prepares you all this, I think it's amazing to have this because of doing it by photos. But is there anyways the point where you send either the dental technician to see the patient at your office, or you send the patient to the office of to the dental laboratory? Is it absolutely enough because you are such a good team between your dentist and the dental technician? Or
after a while it is. After a while it is. If you ask me if I would like to have my dental technician with me, yes, I would. Is it possible? For me, it isn't. But once you get to a part that the communication is, the workflow of the communication between lab and you is perfect, spot on, you're leveled, it becomes an easy process. But of course, there are some things that camera cannot capture and the eye can. So I would like for the technician to be able to come to my office, but that does not happen with me. Okay. So you get these beautiful final restorations. They are pieces of art that our labs can prepare for us. This is the tough work, actually. Trying to mimic all of this that you see here is really tough for the labs. But if you give them all the information they need and they are well trained, they can deliver this type of restorations. And you can see the tissue looks absolutely amazing after just one procedure. So this technique first came to me, the first time I realized it was reading these articles. And this is a funny story. These articles are from Pedro Peña Martinez, the first guy more than 10 years ago that I saw describing these techniques. And like 2 years ago, I believe, I was in TRI booth, and I was showing a presentation that I recently done. This was in 2018, exactly. I was showing the presentation that I done, and I just mentioned him, and he was behind me without my aware. I didn't know he was there. I didn't even know he was in Lisbon. This was in Lisbon, and the guy was standing beside me with Olga, and I was going through my presentation, discussing, I don't remember with whom, and Olga touched my shoulder and said, look who's here. I looked behind, and the guy was there, and I was just mentioning him. So it was a funny story, and get to sit a little bit, and I get to show him my work. He's a nice guy. So it was the author of these articles, of these techniques that have more than 10 years now. So, okay, so this is one case that you are seeing, that I showed you a bunch of times now, and you can see the same thing with the step-by-step. Implant placed, you do the restoration, you fill the gap, and you can maintain the architecture of your tissues using these techniques and being very careful. And keep in mind, to this moment, we have not discussed any type of tissue graft, only thinking, biology, only tissue engineering. So one small tip before we get to the end. This was an old case of mine. I have done 4 crowns here. It was a bridge, a zirconium bridge, and this tooth had a idiopathic resorption and had to be extracted. So I cut the frame of zirconia carefully, not to damage the ceramic. And even though I did everything like I just told you, placing the implant in the right positioning, touching the palatal wall. Even so, sometimes in lateral this might happen. Now, the only point I'm bringing this to you is that this is more than the 20 to 25 degrees angulation that you can use the tri-base. So, and this was a narrow implant, which adds up a problem because you don't want the restoration to be too wide inside the tissue. Otherwise, you lose tissue, you lose bone. Remember, tissue needs to have space to accommodate. So in these scenarios, even though I don't like it, I go for cemented restorations. And this is the two small tips. I use a jig in order to place the restoration in the perfect spot. And this jig is very easy to be done. So you place it in and you can give torque to your abutment. And I use the tri-bases itself, and they are reshaped, okay, to be a cemented post. This is the tri-base. And the cementation lines should be just at a little bit inside, just a little bit, almost at the same level of the tissue, so you don't damage anything. And I really don't like to do cemented restorations. This is a tip for when you absolutely have to. The tip is keep them as high as you can. Don't go inside the tissue, okay? And take as less space as you can. So sometimes I do this instead of zirconium frames for the restoration. So this is the end result of this case. And after 2 years, you can see that everything is still in place, even though it's a cemented restoration, which I really don't like. So back to our initial case, and just to get to the final of this webinar, you get to see the beginning of our story, and you get to see the end of our story. And this was the placement day. And you already can see that this looks better, but the biotype still isn't. It's better than at the beginning. You can perfectly see that, but it still isn't as beautiful as you wish. So at this moment, I was considering if I should or shouldn't have done a graft, a tissue graft. This is the X-ray. And now I'm about to show you the final control I had for this patient. So remember, this is a 2016 case, and this is the control back in 2018, late 2018. Look at the biotype now. It got boosted. It looks thicker. It looks better. And this is all because of the restorative procedures that we have done. This is nothing to do with grafting, okay? Papillas are in place, everything is in place. But now, working in aesthetic zone can be tricky. The expectations can be high. But in a situation such as this, where you don't have papilla here, this root is completely rotated, the occlusion is traumatic, the patient doesn't want to go through orthodontics, you had up problems and you need to find solutions. So this is the beginning of the case. And in these situations, of course, you need to know how to handle a CTG, okay? It's absolutely important that you try to create what's no longer there. So the steps are exactly the same. The only difference is that we made a CTG, we placed the implant, we go to our provisional restorations the exact same way that I just explained to you, and we wait. And after 6 weeks, some sort of shy papilla is appearing here, the same thing. After 3 months, there's no longer a shy papilla, there's a real papilla coming to place. And after 4 months, there's papilla here, complete papilla, still a little bit of scar here, a big papilla, and the volume looks way better. So handling aesthetic zone, you need to have tools, and you can use whatever tool you find more interesting for each case. And even though if you do everything right, in thin biotypes, this is an immediate implant I have done 4 years ago, and this picture is for 2 years or 3 years ago, 2 years ago. So at this moment we speak, it's 6 years since I placed this implant. And this happened. The tissue moved. Maybe I did something wrong. I don't know. It's more than 6 years now. But even if I did everything right, look at this. The biotype is not helping me. So sometimes the war means more than just a battle. So again, I go in, I do a CTG, I do a tunneling technique. After 2 months follow-up, it's looking better, but not quite. But then after 1 year, it looks like this. And I just controlled this patient last week. I don't have the photos with me for 2 weeks ago for obvious reasons. I still have nothing from my office. We're stuck at home, but it's looking even better than this. So it's important that you understand that you need to work with the tools you have, and sometimes it takes more than just one battle to win the war. And just to finalize some key points for you. So sufficient basal bone left to achieve primal stability, a traumatic extraction and decontamination of the socket, correct implant diameter choice, remember José Carlos Rosa, tissue management more than tissue grafting or combined, and provisional restoration, but always think about tissue management. This is very important. Individualized impression copying and lab communication, remember the macro photography, and a little tip about the ceramic itself. Final restorations, T-base and true zirconia restorations, and always keep irrigating your tissue. Keep them moist. It's very, very important. So of this, we'll discuss the next session, and I hope you all join us. This is something that I'm very passionate about, full arch approaches. This is where I begin. Where I start doing lectures what about this topic, about full arch restorations. So it's in the 8th of April, and back to you, Olga. So keep on, my friend.
Thank you very, very much for a very interesting webinar, Joel, first of all. I'm going to switch to my computer again to have a little question and answer session. I tried to ask you a lot of questions already during your presentation. There's one big question: indications for immediate placement. When would you do, when not? What's the bone situation? What's the patient's health? There was a question about the sickness of patients, and when would you do it, when not? Maybe this is a topic we can discuss also on the 15th, but maybe you can answer a little bit.
That is a very big topic. Of course, like you saw in that slides that I showed you, of course you need to consider the oral health of your patient. You need to consider the I'm sorry, but my webcam just went off. You need to consider that. Is my screen off now? Yes, it is. Okay. Yes. So you need to consider the systemic health of your patient as well. You need to check for occlusion. You need to know how much bone you have left, if you can or cannot achieve stability with your implant if you do an immediate approach. So there's a lot to consider. So it's a big topic, but most of the times it's possible.
And there's a question of Michele's Tilipos. 3 months is enough for upper jaw to wait?
Sometimes it is, yes. It depends on a lot of stuff, but mainly in between 3 and 4 months, yes. If it is too much implant contacting graft, then I would wait a little bit more. But if it's mostly on bone, 3 months may be enough, yes.
There's one, thank you, from Tom Saxon. Hello, Tom, good friend of us. Excellent presentation. Thank you, Joel. Do you? And then there's another question. Do you go for immediate implant for smoking or for smokers or not?
I go. Yeah, I do. Okay. I do. So knowing the risks, I do, because if you don't, you'll end up losing more anyhow. So it's better to try to preserve what you have than to lose it and trying to regain it. So that's my main thought.
There's a lot of questions also regarding intraoral scanning and so on. There was questions why you don't copy the temporary in scanning and do the scanning techniques. Digital is a topic. I think we do a little bit more in the next session on the 8th and also on the 15th. But the digital gives me the point to overtake this webinar for a second, because I think that I started in the beginning, that our company TRI is really focusing on the digital workflows, and I would like to take the chance to just like say that we're going to have our digital festival also in Portugal, in Cascais, in beautiful Cascais, close to Lisbon, and there we're going to have the big worldwide launch of the first digital implant. I can't tell you a lot more about it right now, but it's going to be very exciting. We are working very close also with Dr Teles on this project since more than 2.5, 3 years. And I would like to invite you for the digital festival on the 25th and 26th of September in Cascais. Maybe take a look to our website, where you can see already the most of the speakers are signed up. There's some special guests from Switzerland also being announced soon, but there will be Maris Deichmann, Ramon Gomez-Meder, the Anini brothers will do a live surgery in Italy during the time we are in Portugal, looking to their live surgery, and the dental technician is creating what you just explained, Joel, virtually on stage in Portugal. I think we have a big party at the end, and we have the chance to see you and your brother, who is a dentist too, playing some tunes for us, or not tunes, you playing music. So we see you playing your guitar and so on. Take a look at it and be a part of the next session. Write your questions to us. I just show on the last slide the email again, where you can write your questions to this presentation. At the 8th of April, we're going to do the full arch immediate placements, immediate loadings session, which is a really big topic. And I hope I could answer a lot of the questions right now during the presentation. The 15th of April is going to be our session where we do a very interactive time. We have some new stuff to tell you, so it's not only repeating the old stuff, or not the old stuff, but just the stuff from today and the next week. But be a part of the 15th as well. And there's really the possibility, send your cases, send your questions, send your x-rays, send some experience or whatever, send it to the academy at tri-implants.swiss. We try to work out the best solutions for the 15th, and now I would like to wish everybody a very good week, and stay at home, please. It's very important in our days, and stay safe. We try to keep the knowledge up here, and thank you again, Joel, for a very amazing presentation. Thank you very much.
I thank you all. Thank you.
Bye.
Goodbye. Goodbye.